Start, please. Okay, welcome everyone. So welcome everyone. Apologies, we've had Simon, Jack, Alison Smith, David Sidaway, Neil Kathy Riley continuing this place, Harry Turner. The good news is that Harry's back at work next month. And also, it could announce that this is Dr. Julian Foley's last month. So we'd like to thank you very much for enjoying your support of years. The wise voices that you put on this. Wish you well in your new role. Attending by links, we've got Stacey Keegan from RJNA. Okay, just a bit of the rules for today. We've got a lot of paperwork to get through. So if speakers to each page, we can just raise a couple of key points for introduction to the paper, and then we can assume that everything else has been read. Thank you. Declarations of interest. Any declarations on any item on the agenda? Minutes of the meeting held on the 27th. Any points on accuracy, omissions, and the content? I just have one point to note is that there is a change to the agenda, sorry, to the minute which says that NHS Shropshire, Telford and Wrekin Integrated Care Board accepted the report as an annual position of the maternity and neonatal services at Shropshire, Telford and Wrekin. This goes on to the report themselves. Acknowledge the acceptance of that. Moving on to the next item, which is the matters arising and action list from the previous meeting. By and large, those are all in hand, so I wasn't going to labour on any point at this stage, but I think we want to raise them with me at this stage. Okay, thank you. Moving on to the Chair's report, please take it as read. Just a few points for me. First of all, as I've said in the report, a big thank you to everybody across the system for all their work, right across from social services, point of care, community to acute and mental health, for all the work in the last few months. It's been a very challenging time, but we are getting there, and we've got a lot further to go yet, but I'm very pleased to note the contributions that everybody has made, both in the team and as individuals. I think the next item, just to bring to the attention of the board, is very much a big concern about finance going forward. We haven't yet had the planning guidance from the government yet. That's been delayed yet again. But I think it's fair to say that we can expect circa 2% real terms cut in our budgets for the next year, 25-26. That will require a lot of rigorous thinking right across the system. And that is looking at fine, detailed, rigorous examination of pay. Every post should be examined. I know it's going to be difficult to do, but we have to do this work. We have to justify every post in terms of its contribution to patient care and governance. We have to look at all our non-pay to make sure that we are exacting as much as we can from our contracts and our procurement. I won't go any further than that, but I think there is a concern that I have as chair at the moment, is that the rigour needs to be stepped up a lot in 25-26 of that whole process. And I'd just like to bring in Dave at this point as acting chair of the Finance Committee to bring out a few points on that.
Yeah, thanks, Trevor. So one of the things that we're looking at in the Finance Committee, first of all, I think we've got to make sure that we get the right attendance there. We had a little bit of slacking off on that, which I think needs to be done. However, having said that, I'm very keen that we need to start moving the agenda onto one of trying to work together as a system rather than selectively going around and beating up provider after provider. We've got to draw through a lot of the things, because some of the things we are going to be facing into next year in terms of how we deliver efficiencies and productivity improvements we need to look at are going to be across organisations, and it's important, I think, we start to drive a narrative along those lines and start to understand how we work together more effectively as a system. I think the challenge will be strong, I think, also next year, but that has to happen through the operational line. What's important at the Finance Committee is that we start to understand, do we really understand how we're going to deliver these benefits, and the challenge will move much more onto an understanding of, do we really understand the drivers of some of the outcomes in terms of finance that we've got, and what are we doing about those collectively? So I think that is important to start to change the way that we're doing it to make it more effective and deliver greater value, I think, to the system.
Thank you. I would also add that there's another opportunity which we need to look at with great diligence as back office function. And I've had a chat with Andrew, who now will chair the transformation and digital group of the system. And there's a lot of work to be done on back office functions, which we need to move quickly. This morning I was looking at papers because I work for the backcountry system as well. And they are at an advanced stage in terms of their examination of back office functions. So we have a lot to catch up in terms of how we economise and get greater efficiencies right across the process, from HR, finance, contracting, IT, digital, etc. There are opportunities there quickly. And I think that's the importance of this board, the urgency of this whole part. I don't think this stage.
Probably not. I want people to like it.
So that's the bad news about finance. Oh,
yeah, just wanted to say that yes, I understand what's being said about budgets. We've had to make 181 million pounds savings over the last 13 years. But what we've done is not just look at how we cut those services, how we merge those services. We've also looked at how we invest to save, things we can do that will stop some of the pressures on the hospitals, things that we can do to support primary care, and those things need to be looked at as well as part of that process. I think it's part of the financial process as well. And unless we do that together and say, what are we doing with the preventative work that we need to invest in to get the savings that we need later on down the line, it's really, really important. And we have to do that with both children's services and adult services in local authorities. And I think it'd be really helpful for us to be looking at that kind of approach when it comes to savings in the future.
Very good point. So lots to do on that score, and I think from now on forward, this will be very much a high priority issue. Any further comments at this stage? Well,
I suppose one Jess, but just building on that, you touch on it in your chair's report in relation to under 5.1 general practice and the need to kind of look at shifting more specialist resources out in the community in line with the priority moving forward. So I suppose that's the bit for me, is alongside everything that's been said, it's kind of in support of the last comments, it's getting an understanding as to moving forward, where do we want to be as a system, you know, with all of this and coming together to do things differently, more efficient, more effectively moving forward. So I sit here sort of temporarily chairing the PCI committee, and obviously want to really, you know, have some good conversations around resources moving forward. But I think we've got to get to a position where we understand what sort of a model are we moving to in the future, so that we can really then start to help from a people perspective, make sure we've got the right skill mix moving forwards, which kind of then links into finance. So there is a bigger piece there for me alongside the streamlining of back office functions. I think that is a fundamental piece of work, and it may be that that's being done at policy time, it's not decided on that.
conscious of time, but we'll move quickly here. Trevor, then Lynn.
Well, just a question related to that. Is it clear where the conversations happen? Or whose job it is about the shared services or these that we need?
Well, it's very much within the collaboration that's within Andrew's remit steering that group.
And we met this morning, obviously, this is prior to Andrew joining the group, but certainly I've shared on behalf of Simon, and that was one of the conversations that we had as a group of chief executives this morning in terms of how we really put the right focus and energy into that work. So there'll be more to come to.
Yeah.
And just in the absence of anyone from the BCSE, I just thought I'd mention that sector as well in terms of how important they are to be part of those conversations, and the fact that, you know, some of the services might be able to be offered slightly differently by different people.
Just to pick up Martin's point, so there is work that is reaching a point to both share and then to report about our system approach to integrated neighbourhood teams, obviously working collaboratively with our local authority partners across the NHS, and that absolutely includes the voluntary sectors. So that will not only bring together our approach and think about some of the configurations we've got, that work that comes from place and for being boards as well. But that will be a really important component. Not the only thing, but I think a number of discussions at the moment are in place. I know, Roger, we've been talking about how we make sure that we've got appropriate links.
Very quickly.
Yes, very quickly. Just on that point, I think one of the things I think we will absolutely have to do next year in terms of facing into the challenges, I think we've got to be very rigorous in terms of our own lines of sight and governance, etc. If I do look at us compared with a couple of other systems that I know well, we do have a much more convoluted governance structure in Shropshire than is done elsewhere. We've a number of these things travel across different groups, and I think we lose a lot of line of sight because of that. I think we need to be thinking about that.
Thank you. Only final comment is that the recruitment for this substantive chair is proceeding well. There was a good feel on the interviews on fingers crossed. Thank you. Questions from members of the public. We've had 11 questions and they will get responded to in court. Right, resident story.
Hello everybody, I'm Rachel Threadgold. I'm Senior Health Improvement Practitioner at Telford and Wrekin Council. Today I'm going to give you a brief overview about the community outreach blood pressure project that we've been delivering since July 2023, and that's been led by our Health Improvement Outreach Coordinator, along with our volunteers, who are our health champions and our blood pressure checkers. We were due to have a patient story today, but unfortunately Sol hasn't been able to join us, but unfortunately for us, but really great for him because he's secured a new job, which is really fantastic. But we have gone over some questions and I'm going to read those out to you, his response, because I think they're really, really important for you to hear. So since the start of the project, we've checked over 2,000 people's blood pressure in Telford and Wrekin, and of those people, 31% had a high blood pressure, and around 61% had a normal blood pressure. 8% of those had undetected high blood pressure in the first part of the project, and in the second part of the project, that rose to 16%. We have been checking more older people's blood pressure, so there is a need for us to really engage with that 40 to 49 year age group, and particularly men. We all know, don't we, that if we can screen hypertension and check people for high blood pressure in the community earlier, we know that that's going to save people from having a heart attack, a stroke, and also dementia. And I think the key figures are around that. If we stop somebody from going into hospital and having a stroke, you know, that costs around £45,000. The scheme that we're delivering costs around £55,000 to deliver in Telford and Wrekin. So there is lots of efficiencies around that, and it's a really effective programme. When we think about our areas of deprivation in Telford and Wrekin, we've got 18 of our wards that are in the most deprived in the whole of this country, comparable with inner cities. And so when we think about the people that we've engaged in the first part of the project, 26% of those people that were coming forward for those blood pressure checks were from those deprived communities. In the second part of the project, it's been around 20%, but this, we think, is because this figure should be increasing really, and that's because we haven't been checking the details of where people come from who are already being treated for hypertension. So we missed a bit of a trick there, but we will be altering our systems to make sure that we're collecting that data going forward. In terms of ethnicity, in the first year, 24% of the people coming forward for those checks were from our Black, Asian and ethnic communities. And in the second part of the project, that rose to 27%. The majority of the people who are coming forward are white British, but that's closely followed by people from our Asian communities, our Black communities and other ethnic groups, including Chinese. So I think that's a really good figure. I mean, in terms of our targeted scheduling, our targeted comms, in the first part of our project, we actually did around 61% of our events were in those areas which were of high deprivation. And that's pop-ups, that's events, anything that we've been invited to, anything that data's telling us where we need to go. But in the second part of the project, it's increased to 74%. We've been working closely really this year with community pharmacy. So anybody with high blood pressure in those community settings, we send to community pharmacy to have the ambulatory blood pressure monitoring done. And then we're only referring to GPs, those people who've already been diagnosed and treated for hypertension with a high blood pressure. We make use of the council's healthy lifestyle service. So effectively, where people are telling us, I need to help reducing my alcohol consumption, I need help getting more active, or I need to help in stopping smoking, they're all referrals to our free lifestyle service, which I think is really important, and volunteers are always making those opportunities. In year one, we trained 45 volunteers. Now, not all those became active volunteers, but I think the important thing to remember is, because they've been trained, they know how to take someone's blood pressure, they know what the reading says, and they know therefore as well who to signpost to in the community. So I think that's a really valuable skill that someone's gained. In the second year of the project, we've trained so far 78 volunteers. Now we've scaled up the project because we're working with the voluntary community sector to ensure that we, I think the trolls say, don't they, no troll left behind, and we're really trying to ensure that everybody in our community can have their blood pressure checked. So talking about volunteers, before we go on to our patient story, Deanne has kindly come forward to talk about her journey, how she got involved in the blood pressure project, why she got involved in it, and some of the things that she might have encountered along the way.
Hi, as Rachel said, my name's Deanne, and I've been with the project right from the beginning. I was one of the first people that was trained. Found out about the project through the health newsletters, which I received, but also I looked on the Telford and Wrekin website. I retired in April 2023, so I was looking to do things that I could get something out of, I could give something back. I went to see Ruth Edwards at the Independent Living Centre, and I'm a volunteer for them. And then, of course, got this project and saw Chloe, who was the coordinator at the time, told me about the project. It was new, I didn't know anything about, health champions, the blood pressure project, what it would entail. So, I went forward, said yes, she accepted me, did the training, which was also then followed on with every contact. So, with that tells us that, when we see people, it might be something else that could be led on, signposting, etc. I have found it really helpful for myself. It got me into communities that I might not engage with. Along to a lot of events, and sometimes I chose events and think, well, I don't know anything about that, so I'll go along. So, I'm giving something back to the person I'm seeing, checking their blood pressure, but I'm getting a lot back because I'm learning stuff as well. One of the main things that we do come across is people come in and they say, yeah, I'm healthy, don't need my blood pressure checked and what have you. We found so many that, you've done the read, you do a second read, you do a third read. And there has been incidents that we've had, we called an ambulance, but of course the ambulance is not going to arrive because they've got a waiting list as well. So, they've either gone to A&E, they've been signposted to, GPs if, it's not that urgent. So we don't know, or I don't know, how much we meant to some people. We could have, how many heart attacks, strokes that we have prevented. I think this project is really, really important, and hopefully funding will go into the next year. It'll keep me out of this year, but hopefully it will go into communities that don't kind of stay or too scared to go and, to go and get their blood pressure checked or anything else. We've signposted people, so someone's got a high read where it's not urgent. Community pharmacists, the GPs. If they're waiting to see the GP, they can take their, the sheet along with all their reads and information that they've got from us. I signposted people to AGK, the Independent Living Centre. So anything that, you have a conversation, and sometimes your conversation can be quite half an hour. So, you're not rushing the person, when they come in, you give them the time that, what they need. So, as I said, it's really, really important, and, I think we are making a big difference. That's my personal opinion. But when people come in, they all say, "Oh, I didn't know this was happening." But also, my own social group or my other groups that I go to, or my friends. I talk about, if someone's mentioned something, you can lead on to a conversation, and I know acquaintances have gone to the sessions that we held. A couple of times I have been there and what have you, haven't taken their blood pressure, because I think sometimes, if I've got another checker with me, they can do it, because I think sometimes you don't want that. So I hope that helps, and I think it's making a big difference, and sometimes we don't see what effect that we have had. You don't want any of your family member to go through a stroke, a heart attack. I mean, you're medical clinicians and what have you. I'm a normal bod. I've seen people, friends, family, and the job that I used to do when you did assessment. What effect on their life, their livelihood, their independence, wherever. So hope that helps.
Thank you. Thank you very much.
I think one of the things that I was talking to Jan the other day, we all share the same values, don't we, about improving our residents' quality of life. And we wouldn't ever want to see our family and friends go through pain caused by any of the conditions that we're talking about today. So it does come from the heart. It's a heart project, it comes from the heart. So we will move mountains to make sure that we reach the people that need to be reached. So talking about the people that need to be reached, that moves me quickly on to the patient story from Sol. So I asked Sol, how did you find out about the Community Blood Pressure Project? He said, I attended a community event where my wife was catering to visitors. So the event he's talking to or alluding to was the day where it was the Afro Health and Heritage Day. And we'd worked with a local CIC who had just been formed to put on the event. Of course, we had our health coordinator out that day, our volunteers. So they were sort of trying to engage people who were part of the event to come along and have their blood pressure taken. So again, so he discovered that he had high blood pressure, and he said even though he thought he was healthy and he was not likely to suffer from it, he still went and had his blood pressure checked. So I asked Sol how he felt when he was told that he had high blood pressure. He said, I was shocked. I was in disbelief because I had no obvious signs or symptoms that had anything wrong with me. So, I mean, like, obviously, you know, a lot of us think like that, don't we? We all think we're, you know, really healthy and we're not going to go along to get any checks. But actually, yeah, everybody in the community, you know, benefits from having a check done. I said to Sol, like, if you hadn't received this support from the Community Outreach Project, what did you think life would be like now? He said, I dread to think. I'd still be thinking that I was in good health and not considering having a health check-up. Sol told me earlier in a conversation that it's not his culture to go to the doctors. And you only go if you're ill, really, really ill. He said, because you don't want to be taking away someone's appointment who really needs it. And that was quite insightful to me because I'd never heard that before. You know, when we talk about barriers, but that's like a positive barrier, isn't it, in a way? And asked him then if he'd made any changes as a result of having his check done. Sol said, I've changed my job. I was working nights. I was advised by the doctor that this had contributed to my high blood pressure because of my age and sedentary work conditions. I've taken up some exercises and walking a lot more to improve my health and heart condition. I have regular checkups and feel much healthier than I did before. I asked Sol if he thought there was any barriers people face from having it checked. I think the barriers include knowledge and availability of easy to understand information that explains the benefits of regular health checks. I believe that the services like this should be promoted more effectively to the community because the people who deliver the community blood pressure service are regular people, representative of the local community. They are easier to talk with and they don't make you feel judged or feel you're wasting their time, as sometimes it does feel with doctors and pharmacy. Sorry for doctors and pharmacy. Finally, I asked him what he felt the benefits were having of the Community Blood Pressure Project in Telford and Wrekin. The benefits are a healthier community, a saving of time of doctors and pharmacy, thus allowing them to deal with more severe problems. We need more of these services in all of our communities. So, yeah, again, thank you very much to Guianne for coming along today. Great talk about your journey, and thank you for the opportunity to just share with you, you know, about our project in Telford and Wrekin. Sorry if we've taken too much time, but we do really appreciate it.
Rachel. Thank you very much.
Standing, so thank you. And we need to make sure that we're keeping you well occupied. So, but I think there's some really important themes. And folk may remember when we were doing the vaccination, still do vaccination program, when we were in the height of COVID. Do you remember the buses going up to the homeless community in particular? And I remember one gentleman saying, it's not that I'm not interested in being vaccinated, not that I'm not interested in my health. But if you're living in a chaotic life or you've got to worry about getting the rent paid and other things, this becomes far lower down in your stream of priorities. And you're absolutely right. Often, if people don't feel unwell, they don't want to be displacing or taking away from somebody else that might need that appointment. This is also about empowerment, isn't it, to individuals? Because in doing this test, you're taking some control. You feel valued as a person. B, you're starting to take control over your own life and your own health and make positive choices. And having that conversation with a normal person that understands where they're coming from.
We do make sure we tell them that we're not clinicians, and you know the role could be reversed. They could do to me. So you know, white coat syndrome. You've got to you put them at ease, and
But also, if there is a problem, making sure
Yeah,
that they
yeah.
understand
very much
the
so.
importance of.
Yeah.
And then that's also about taking control of the house. So yeah, I mean, I think this is something which is very simple, which is so simple.
Just on the point there about the homeless community. So with some of the seed funding that we were given by the ICS to deliver the project in Telford and Wrekin, through a small amount of funding, just even in the last quarter, we've been able to fund KIP and Man in Place, two of our key organisations in Telford and Wrekin who support the homeless community. Because again, by them engaged, they've got more time in terms of working with their community to engage them. But the valuable thing is those volunteers who are doing that as part of that project is they'll be able to go on if we were to be able to retain attract funding for next year, then essentially those people that we've trained will be, they have a business sustainability out of it because the coordinator that we've got in place can continue that training. So again, it means that the reach and engagement is always there.
Yeah, I just want to say thank you. You guys are doing a fantastic job that GPs can't physically do in the community and deliver such an important surveillance program. So I think you guys are going to be really important as part of the integrating into a team. You guys are part of that, you know. So how do we make sure that longer term that we don't duplicate what we do? Because GPs have our own recall process for patients with hypertension. And how do we select the right locations to target those specific areas down to ward level? In that we know that this ward have a particular high, for various reasons, they have a high prevalence of hypertension that's undetected. But because of various factors due to demographics, they might not be engaged with the health check programs that run by GPs. So if we can work together, identifying those key areas that we can focus on efforts on, one, we don't duplicate, and we actually will stretch our bilateral capabilities a lot more in a targeted way. I think it is one example where we can collaborate.
Yeah. So one of the things we have been doing in South East Telford is working with research and medical practice. So those people that haven't been seen in the last 5 years or have been basically sent a text message to say, come along to the community session. So that's been a really good way where we've shown that we've worked together to, save your time, but also hopefully that they're more likely to come to a community setting.
Thank you. Paul and then
Just picking up on the preventative side of it, it's a wonderful project, and I'm really proud that we're part of that process. It is about partnership, first of all, and that's really, really important. The partnership between ourselves and the voluntary sector and all our community sector in Telford and Wrekin. It's been key to our processes across the way. The important thing, I think, and the thing about just the kind of what you're saying, the thing about people being hard to reach, you know, guys, is they're not hard to reach. You just got to go where they are. You know, somebody once said in the preventative program I was involved with, said, I'm not hard to reach, I'm here every day. So why aren't we there? What we've got to do when we're rethinking our services is think, how do we get them to where they're most needed, and the people that we most need to support are going to get those services. I agree. And we can only do that in partnership, and data is so important in that process, and sharing that data together. You know, PCN's working alongside the community sector to say, how do we make sure we meet those people? I mean, there's so many other things that we could be working on, COPD, all that. I mean, there's so much that we can do in this way if we're doing it right and we're doing it together. And I would, again, say TWIP and SHIP have got a huge opportunity, I think, in terms of making that work for this organisation.
thank you. Very good point, Paul. Lynn and then Claire.
I think as Chief Officer of Health at Shropshire, even though I'm from Telford, I think it's only right that I ask about the offer that's in Shropshire, and because of course some of our communities are even more hard to reach in the sense that you have to go out to find them, including our farming communities and those much more rural communities. So can anyone just say a little bit about what's happening in Shropshire? Thank you, Claire.
Yes. Come back to that, just Claire, very quickly.
Yes, so that was going to be what I was going to say actually, if that's okay. So the project extends across Shropshire, Telford and Wrekin. It was just that I heard about this particular patient when I was at Telford and Wrekin's Health and Wellbeing Board, of which I'm a member. I suppose it's just, I really want to highlight prevention, given the discussion that we had earlier about the money. Prevention is a really cost-effective way. It's not going to come out next year, but this is a really cost-effective way of affecting our emergency care, the outcomes for patients and their lives. Sol's not here because he's got a job. That's fantastic, and that's what we're really looking to doing. So that's what I wanted to.
Thank you. I mean, I've certainly seen it happening in a dementia event in Bridgenorth myself, and I made use of it. And every time I see somebody, I'll have mine. If they're not doing anything, I'll go and get mine done. So it is a value.
Thank you. A very good discussion, and thank you, Rachel, Leanne, and thank Sol as well for his account of his experience. Just putting a few threads together. This is great, but it also needs to be coordinated with all the other stuff around, like the GP setting up text messages saying take your BP and all that sort of stuff. I suppose my question is, and Matt, maybe this is to how confident are we that we have a strategy around prevention of strokes, heart attacks, regarding the screening of IBD, etc., and that we have that neighbourhood focused at the same time, because that it has to be through the neighbourhood. Any thoughts?
Yeah, absolutely, and I think that is the key. I think the three shifts that we're hearing as part of the narrative, coming down following the Darcy review around sickness to prevention, hospital to community, and a lot of digital. It very much kind of fits with this and where we need to be going forward. So I'll talk later in part of the primary care delivery and planning paper about how we're working towards integration of community pharmacy into that broader long-term conditions management. But actually hearing about programmes such as this one, what we need is, as we Claire and team are doing a fabulous job around mapping everything that is available in our integrated neighbourhood teams. But it's about using our data and intelligence to understand where are all the offers like this? How do we bring them together? How do we make them visible? And how do we connect them? So one of the pieces of work that we'll be doing is a primary care strategy over the next year that will absolutely need to be aligned to our integrated neighbourhood team way of working, with that prevention built in, running straight through though. And I think that will give us that real alignment. I think the commitment for us to deliver it in this way is there, absolutely seeing the value of working with residents. Because I think this approach to what some through the tackling of the health inequalities, meeting people where they are, and that's absolutely what we need to start.
So my next question would be, when can we as a board see that coordinated, data-driven approach actually up and running? I'll leave it with you to go. But that's the sort of action that we need on this. And great that the volunteers are helping in the process. Good, thank you very much. You can stay if you want, or you can go and do some fun or interest. Thanks for your time.
Thank you very much.
Right. I'm moving on now to the CEO report.
Because it's usually the case, Simon has highlighted some key areas that will be of interest to the board. And I think just reflecting on that list, the one of note, which links absolutely perfectly with the last conversation, is the visit that we had earlier this month from regional NHS colleagues to talk about the good work that we're doing around health inequalities. So that's probably the area that I wanted to just draw attention to, particularly given that link. We've had some really strong positive feedback from that session in terms of the breadth of our teams and staff who are involved in health inequalities. This is not the domain of one person or one team across the system. This is something that everybody sees as of value and something that we want to drive forward. So I think it was a prime opportunity really for me to draw attention to that section. I'll do my best to answer any comments or questions, and certainly the colleagues can help if there are specifics.
If I may, just to add a little bit more. Our group within Shropshire, Telford and Wrekin is actually chaired by our Director of Public Health from Telford and Wrekin. So at its very heart, it's a an integrated approach. We work really closely, and obviously with Rachel was a colleague in Shropshire. So this is absolutely an integrated approach, working with NHS, local authority, and partners from across the system. I think the other bit, and just your point around in terms of data-led approaches, well, that is absolutely already in place with some of this work. So we absolutely want to build on that, what Laura was saying. But if I look at, for example, the work looking at diabetes in children and young people, there is one heck of a lot of work looking at the differences between different communities, different ethnicities, and other different factors that are really and supporting the people just with the left on. So the other bit I would say, within Claire's team, our business information colleagues, again from both NHS and local authorities, that the information and the way in which they've brought together a dashboard to look at categorisation of residents, down to locality and other different groups, is a fantastic tool, and built from the work that colleagues have done on population health management, means that we've got that real intense focus that we can use for a whole range of different pieces of work. Absolutely data-led, but it's a joined up piece of work, which is what
Thank you. Okay, moving on then to the chair. Sorry.
I was waving at you, but I couldn't. I was just going to ask about the change NHS consultation, and whether we have any information about how many people and organisations across Shropshire and Telford and Wrekin have actually submitted responses, and is there anything else planned to promote before the consultation closes, which I think it's Valentine's Day or something like that. So, I mean, if you need any support with that, because I think we've offered previously, if there's any promotion of any activity, we'd be really happy to support with that.
I don't have that involved. I mean, are you going to help me out?
Yeah, I am going to help you out. Yeah, there are events that the ICB are running. Okay. So I would be surprised if Telford and Wrekin Council hadn't been made aware of the public events that are happening. Yeah. So I'm sure somebody will contact you with the details of that, because there are a few more ongoing. But any community group can do the engagement in a box resource, which is on the website. And also, if you look on the Change NHS website, you'll see that there's already some quite significant findings come through so far from the public survey and the organisational responses. And we as Health Work Shropshire have been promoting it as widely as possible and built our own response to the questions as an organisation.
We're using every avenue that we can. So, as well as our public facing community events, we're running sessions internally for staff. We're trying to maximise really our opportunities to get the messaging out there, but also encourage people to come back and comment. I haven't got the stats virtually written down, but we'll be able to collate that. Yeah.
And just as an addition to that, so each organisation has to submit a response, an organisational response, by the 2nd of December. So we all, as providers and commissioners, actually communicating to our staff very collectively around both as not only as NHS employees and staff, but also the majority, 90% of my staff are Shropshire residents, so as residents and patients themselves to comment. And we did that in concert with each other, as well as then doing our individual response. Obviously, our response as a community provider is in what we can provide as community services in relation to some suggestions. So yeah, we all did that in concert, submitted the organisational responses, the deadline of which was the 2nd of December, done that. But the ongoing local discussions continue, as you say, until mid-February. Thank you. I think the publication of that 10-year plan is in the spring. That's probably an NHS spring, so December.
Any small TV debt report? And the board assurance framework.
Thank you. Just to draw attention to board members that we have made some updates to both the and the SOAR, and they're detailed in the paper itself, and particularly for the back. I think we may have mentioned here previously, certainly the Finance Committee have taken some time to review the risk item number 2, which is all about use of resources and our ability to be a sustainable organisation financially. So you'll see in the paper that we've now split that to be a bit more user friendly in terms of what we're trying to define in terms of our aims for finance. We've also realigned this 3 to make sure that we've got that specific focus on health inequalities given the challenges that we've got in the system. I wasn't intending to go through into any more detail, but I would change to feel any comments or questions.
Okay. Any questions on the back? Okay. You know, the primary care delivery plan.
Thank you, Chair. So this paper essentially seeks to inform the board on the progress in terms of the ICB having taken responsibility to the commissioning of pharmacy, general ophthalmic and dental functions on the 1st of April 2023. It talks a little bit about the governance, the priorities and the performance, as well as some of the risks involved in the commissioning of the wider primary care services. The paper sets out that the governance is mostly managed for us by the Office of the West Midlands, which has 3 tiers, and we're involved in them all, but it also sets out the route by which the ICB oversees what happens there through the primary care integration and transformation group. The paper does recognise some risks around the governance, particularly that the PCITG, the primary care integration and transformation group, tends to be more focused on pharmacy and general practice rather than optometry and dentistry, largely due to a lack of representation. The LDC and the LOC, the local committees for dentistry and optometry, are really keen to engage, but with the difficulty around providing finance to backfill their representatives. It's also recognised that there is much more conversation around operation performance in that space rather than those wider strategic integration and planning conversations that we want to be having, although plans are in place to review the governance. Just a couple of highlights. So we know access to dental care is a real key priority across health and care, and a real source of concern for our residents. Just to provide assurance that there's good progress, a positive trajectory in dental access for STW. So our children's dental access is now at 101% of pre-COVID levels, with 64% of children having been able to access dental care in the last 12 months. Our adult performance is above the national average, but it's only still at 80% of pre-COVID levels, with 41% of adults having access to dentistry in the last 12 months. So still a long way to go. Really good plans in place being developed by the Office of the West Midlands based on a dental equity audit, which showed us where those real areas of inequity in access to dentistry were, and started to put into place some real targeted schemes to increase the ability of providers to overperform against their contracts in those places, and we've had really good uptake on that. Just a few words about pharmacy. So we were talking about how community pharmacy is really expanding to support general practice and the urgent and emergency care system, and that we're one of the few systems with 100% sign up to Pharmacy First, which is really good. In the last 6 months, they've delivered the equivalent of 4 full-time equivalent clinicians worth of time saving for general practice, which is a huge amount actually, and making a real
a real difference to patients who can access services quickly. They're undertaking blood pressure checking, atrial fibrillation screening, oral contraceptive consultations, and we're looking to build that out into provision of further long-term condition management, things like opioid prescribing as well. So looking to use those skills in a really different and innovative way. Optometry are really keen. They're at procurement for an optometry first service, which will step into that space around direct access for people with eye and sight issues. And then finally, just to say, there are a few risks around the expansion of these services. So as we provide more through our pillars of general practice, we're going to need improved digital capabilities, which is something that I think is worthy of discussion in the future, as well as expanded estate. There's also going to be an increased demand on the workforce, and we need to make sure that we're absolutely sighted and ahead of that in our planning with our higher education institutions, as well as our workforce trainers providing that training. The final overarching risk is that a key element currently missing is that strategy that Roger was referring to, and that we absolutely need that to drive our integration. We heard earlier about what is our destination, where are we going as a system, what do we want it to look like? And I think we need to absolutely explicitly map that out with our partners, and that's something that from a primary care, all four pillars perspective, we'll be looking to do over the next 12 months, alongside the integrated sustainable teams work that's taking place. So I'll stop there, Chair, and I'll just invite any questions.
Thanks, Lauren. Deborah.
Yeah, I think this is absolutely the right direction to travel, isn't it? These are primary care services, and they should be delivered down to commission. That's the level of primary care within an integrated care board and the wider neighbourhoods. My question really relates to having previously been in commissioning and transfer of primary care services, the due diligence around it, not just in terms of making sure that the right budget arrives, so you've got something to work with, but also the resource around managing the commissioning in terms of skills and capabilities and managing commissioning for optometry, dentistry, make my brain burn, just around the whole contracting piece and commissioning piece, and it does require skilled labour and skilled workforce to do that, as well as the individuals that are actually delivering clinical clinics itself. So it's, are we confident that the budget is going to come across in totality, and B, will the resources with it to support the commissioning of thereafter? Yeah, absolutely. I think we are much more confident around that now than we were initially. We have quite clear line of sight on the budget now, as well as on the kind of workforce that was we had some dedicated staff that were transferred to us, that they sit within that hub in the Office of the West Midlands. What we need to do now is work more on our dedicated capacity for the ICB. Most ICBs have a dedicated lead commissioner for pod commissioning, because, as you say, it's a fairly technical but also laborious process. And so once we have our primary care team up to establishment, we're hoping that we'll be able to put somebody dedicated in that space to work alongside much more closely with our dedicated representation of the Office of the West Midlands, to make sure that the plans are absolutely right, dovetailed and aligned, not just with us, but with the local authorities and with all of the providers as
Deborah.
Yeah, thank you. I really want to echo everything you said, and I'm really glad that you watched it here. Having attended this group for the last 6 months or so since I've been happening at the CB, it does feel as if it's feeling its way and not quite sure what it's doing at the moment. It's evolving out of previous definition committee, and it does still feel as if it's very much like an operational performance level rather than triggering transformation. The primary care team attends very effectively, but actually there's little sort of attempts from the wider ICB, so it doesn't feel as if there's plenty of oversight. There will only be a couple of us who aren't actually part of the primary care team. So I think we do need to think about who attends and really focusing on what we're trying to achieve with this group. And then also absolutely echo the need for leadership for the pod transformation.
we have pharmacy representative meeting with the discussion each pharmacy, but because there is no representation from optometry and dentistry in these meetings, we can't have those discussions. So the dental audit that was included here in the paper came to that group, but we couldn't really discuss it because we wanted to discuss it with information. So we do really need to think about some dedicated resource for the wider primary care in our primary care team, which previously is focused mainly on general practice, but we need to be thinking about it.
We did have a discussion about
Yes.
it. So we are picking up. Yeah, and then Paul.
Do you mean me? Lynn?
Yeah,
It's okay. Just a few things from me. Obviously, both health watches have been around for over 10 years now. We cover the whole of health and care, and therefore we have always received comments about dentistry, optometry, etc. So obviously we've done a report within the last 2 years about access to dentistry, and so for me, the thing that people still come to us about, although it's less because I think their expectation is lowered, about the lack of NHS dentistry, but also the lack of family dentistry, in the sense that sometimes a practice will take an adult, but they won't take their children, and vice versa. And the fact that a lot of people, once they've found a dentist, will not move from it. And so some people are travelling long distances out of county to access that. And so we'd be really happy to try and feed what we can into that, and also work with you on that sort of quality piece. The other thing I wanted to mention is we're about to publish our pharmacy report, and we did try and work with the pharmacists to ask them to support us to gather feedback, but we also wanted to hear from pharmacists, and unfortunately that hasn't really happened, because my concern is about the capacity of pharmacists to take these things on, particularly those smaller community pharmacies when they might only have one person who is trying to dispense, as well as that time that it can take to speak to an individual. So I do think it'd be really helpful to hear more about how that's working. And also, yeah, so being part of the work on the eye care as well. So I'd be really happy to get involved and share anything that we've got so far on those things.
That'd be really helpful. I think just on that, the point about people still struggling with access, particularly around family access, one of the things that we'll be able to do from the beginning of April is we can rebase and reprioritise contracts that have been underperforming for the last 3 years without the provider's consent. So we can start to look at those providers that have consistently underperformed on their NHS dentistry contracts, and we can move that activity now, which we could never do before. We know that in STW there's an over-representation of the national providers, where there is a greater tendency to not necessarily perform right up to the value of their contract. So I think there's real opportunity for us to start to tackle some of that in this coming year, and certainly hearing from in partnership with Health Watch, hearing from the public about how that's working and you know, what we need to do would be really, really helpful. So yes, absolutely taking on that.
A lot of people still don't know about Pharmacy First, just putting that out.
Thank you. Paul?
Yeah, just first of all, welcome the co-produced strategy. I think it's really, really positive. I have to say I'm disappointed with the numbers. You know, we should be disappointed with the numbers because it does affect the hospital, it does affect the other services. It's exactly back to what we're saying. You know, the number of children who end up in A&E because of the lack of dental support is frightening, really, in the 21st century here in Shropshire, Telford and Wrekin. So we do need to we need to work on it. We need a proper strategy in terms of, you know, getting to those health inequalities. And I noticed from the report that, you know, those disadvantaged communities are the ones where they're not getting the service. So we need to be targeting that. And we need to do that in a way that is effective in terms of, you know, again, taking those services to the people rather than expecting the people to come to the services, because that isn't happening. Yeah. And it's costing this economy a huge amount of money because it isn't happening. So until we get that right, then I think we'll still be worrying about budgets, you know. So if we can put something in there about different ways of getting those dental services into those most disadvantaged communities, then the better, and the sooner the better. So I think it will make a difference to those statistics.
Absolutely, really welcome that as a suggestion.
Just on that point, clearly this is multidimensional. So it's neighbourhood, it's primary care network. Is that sort of being factored, or will that be factored into the regulation?
It has to be a layered and integrated approach. We can't have silos that we can't have strategy in silo. We absolutely have to start to whilst we need to have a laser line of sight on what's being delivered in each of the different pillars of general practice, we also need a laser line of sight on how we're bringing them together and how we're bringing them together with communities, how the inequalities layer into that. So that's the approach. It needs to be co-designed with practices, PCNs, dentists, doctors, pharmacy, community pharmacy, and our residents. And we need to make sure that that's all layered together in a way that gives us a model of delivery that we can see from top to bottom the way that it works, and it works together so that we maximise those efficiencies, we maximise that access, and we get rid of that duplication and those barriers that people are experiencing. It's got to be that way.
Yeah.
I support the development of the strategy, crack-wise primary care strategy. And obviously, part of that links to the comms and promotional need the public to understand the changes and what can be offered by different people. But I noticed in your report you mentioned about community pharmacies being lost because of financial viability. I wondered how much of an issue that was locally, whether we've lost any local community pharmacies in that way.
I think that there are certainly a number that are at risk, and the team are working really hard to support them. I think there are a number of challenges to community pharmacy finance from contracts as well as commercial costs, estate costs, in the same way that there are to general practice. I couldn't tell you the numbers off the top of my head, but the team certainly have a work stream around supporting those pharmacies.
This is the things just shame. We got the strategy right, we got the comms right, and we're getting people to work in a different way, and then suddenly they weren't there to deliver the services, particularly in the vulnerable areas.
We are seeing not so much the complete loss of pharmacies, but lots of the being taken over by bigger groups. It's not necessarily a bad thing, because actually some of the providers are actually very good, but it does change the dynamic, and it certainly gives people less choice. Because they haven't seen.
Thank you. Any further points? Well done. Work in progress, I think. Thank you. Next item is the Shropshire Integrated Place Partnership Chair, Andy.
Which has really been a very brief update. The report is there. It's useful to point out a couple of issues there. One, this report dates back to the November meeting. There's been a subsequent meeting in January of this year. The things to pull out really from that report are the turning the curve and safeguarding and protection conversation that continues. Began there, Tony Mile, being the Director of Children's Services at Shropshire Council, led on that conversation. There were updates on there were updates on a range of areas: talking therapy services, children and young people's JSNA, the Health Watch report, cancer, and then we had a report on the healthy ageing and frailty strategy. I think it's important to note the conversations have been had over the past few meetings around terms of reference for that group. From my perspective, I think it's really important that we get the connectivity right between that group and this group. I think that's something that we can build on over the next few weeks and months. There's a lot more we can do in terms of instruction from this board, direction from this board, and contributions to it on I think a number of areas have been highlighted already this afternoon in terms of data and information gathering from best use of that and how we can coordinate activity, particularly around early intervention and prevention, much more effectively. So I think it's around how, really for me, that will be the key on the next few months to make some progress in that area and make a real change. Opportunity to really kind of supercharge that. And then finally to flag up a workshop at the beginning of February there with the Health and Wellbeing Boards around priorities, commission intentions, and that whole strategic place. It's of use.
Two quick ones, but I just reinforce, and as Andy said, the open filter strategy is a really important system priority, as is also, but I think this is important. We've talked about it in ICB committees, but it's a key priority area in both our place boards, and we'll bring that together under Patricia's leadership, also in the Health and Care Models Group, in looking at coordinating it. We've also talked about how we also link some of the immediate and short-term work that Joe and Ian Betts are leading from the UDC board, because there's obviously good work going on there, bridging the gap between some of the sort of transformational work and what we want to approach in an integrated neighbourhood team, but the immediate stuff that's going on. And then the second point that you mentioned was just about bringing it together, myself and a few colleagues to get their heads together next Friday to try and build a staff for 10 on the mass of all of that, for people like yourself and the project to then go right out of distance and of updating and just refreshing all of that and linking with the priorities. We'll be doing that groundwork for your approval.
I mean, just picking up that point, it's quite clear that our efforts need to refocus on neighbourhood place, and that's a message that's coming out loud and clear. And the plan is that we will have some discussions with yourselves around how it's shaped, but I think as a board we need to get that far more prominent here in terms of what we can do to support you and that you've got. It's hugely important. It's very much very important. But thanks. Okay, any further points? Anything from Telford and Wrekin integrated?
Yeah, just to say we haven't provided a written report this time because we haven't met since the last ICB meeting. We've got our next meeting tomorrow, and we'll be focusing on one of FWIP's 3 priorities, which is supporting GPs in Telford and Wrekin by preventing and reducing demands. And Ian and some other colleagues will be attending that session, so we'll be able to report back on the next forward.
Thank you. Next item is the winter delivery update. Ian.
Yeah, thank you, Chair. So you'll, the board members remember that Gareth, my colleague, brought to the board our winter plan, and I think in that report it called out the challenges and mitigations that are associated with our winter months and the pressures that we see. I think that has been played out in the last couple of months, particularly in December. So we had a hugely challenging month in December in terms of patients requiring acute services, patients within the acute hospital. That was a higher challenge than perhaps we originally anticipated. Such was the levels of infections going around, whether it be influenza, norovirus, etc. Significant numbers of patients. I'm pleased to say that has tailed off in January, but put a huge pressure on us as a system. Those pressures resulted in a critical incident for 2 days, the first week of January. I just wanted to say a massive thank you to all system partners actually, because the response to that critical incident was nothing but short of outstanding actually. Previously as a system we've been in a critical incident for a number of days, possibly even longer, but actually the response by everybody in our local authority community acute was fantastic. That's actually probably led us to in a better position in January in terms of it has helped better. As a system, I talked to colleagues, it has, I guess, a more subjective, qualitative comment would be it's felt better at working together in terms of mitigating those risks. So I just want to thank everybody for that. But I can't get away from the fact that there are still significant challenges on our UEC pathway for all, particularly the risks within staff. I'm also grateful for colleagues around the further mitigation we've put in since we last provided the report. So I'm grateful for local authority colleagues for providing additional domiciliary care to allow us to pull patients from the acute into the back, so facilitating their return to their original place of residency in a quicker and timely manner, which was better for the patient, better for everybody. It was fabulous. Also, Shropshire community have also currently in progress of providing additional community clinical expertise in our ED to be able to facilitate patients gaining access to services that perhaps they weren't already aware of, and better use of our resources across the board. I think it's fair to say that we are not on our own. It's been common across the entire Midlands and nationally for the pressures in December and into January. I think some reflections from me are that our improvement plan over the last 12 months, we would have been even in a stickier problem if we hadn't done some of the improvement work that's been happening, whether it's in our coordination, care approach, whether it's our care transfer hub, all have made a real difference. But we are significantly challenged. It's also highlighted some of the work we need to do more of in order to put ourselves in a better position as soon as possible to mitigate the demands that's coming through. Such are the pressures. I think the report just recommends that it would be good to come back to the board perhaps in a couple of months to both review how winter has gone, review the improvements that have been done, undertaken by all over the last 12 months, and also we're in that time of planning as well, where it would be good to share with the board the thoughts and the plans around our UEC configuration over the next 12 to 18 months. At that point, Chairman, I'll talk to you. Thank you.
Just to echo the phenomenal response from certain partners in terms of the incidents. But also, I know a few people were at the UEC board yesterday, but just to recognise that actually we know these are numbers of patients, and actually the December was very tricky, not only for the patients and families that came through all of our services, but also for our staff. It was a relentless period. It was being able to reflect on that yesterday, but as Ian said, the point we've learned is you learn more about yourself when you're in under pressure. And actually, some of the things that we want to do is to stand back and see what we can implement at pace. Just to recognise the pressures we went into together, which I think is a reflection of the changes we've made as this year.
Brilliant.
I appreciate what Ian said, and the remark things with these and pressures, but I do wonder, rather than waiting for review, some things possibly need to be fed back sooner. I wonder whether, in retrospect, overlooking supporting general practice during the winter pressures that we were seeing was an oversight. And when help did come, it was rather clumsy and was rather short notice on a Friday. We woke up and said, "Can you put something appointments tomorrow morning? It's really busy in A&E. We'll pay you whatever is needed." And I think what the thought needs to be for some of the schemes, I don't think it's extra appointments in general practice necessarily needed. Some of it is about supporting some of the other pathways. Some of the things that have been fed back to us were around problems with ambulance services. Obviously, there's some patients, we've had, of course, a patient who called an ambulance for signs of category 2 response, doesn't arrive overnight, so they go to the GP in the morning and they're admitted. We've also recently had, of course, a patient that visited 3 times at home ambulance crews. The ambulance crews are reticent to convey them, and then the next day our home visiting paramedics go and admit them. One of our paramedics this week actually waited to make sure that the 4th ambulance crew again try and divert patients away. And there's some other things about the capacity within the system. Some of the things that we put in one of the pathways around 111 cell, I think it's called, in Shropshire. Again, of course, the practice is having a phone call saying ambulance capacity 111, the version order back response capacity, can you just send the GP to see them? there may be very valid ways of dealing with things, but some thought, I think that thought needs to be given about one of the schemes developed about the fallout of work that falls elsewhere in the system and how that can be supported. So I think that where the capacity is needed is realistically about increasing the medical input and nursing, senior nursing input into the community team, into virtual ward and that response to allow them to handle some of these patients that we're trying to avoid going into hospital by managing them appropriately in the community. And also, more importantly, perhaps stepping down people when they're being setting. I think that there's any feedback, immediate feedback about the board, by missing out on those issues, we've actually missed an opportunity, really.
Unhelpfully, which is great, because I think what we've seen at UEC is that your voice is listening in that forum. So we had a conversation this morning about that exact forum, because yesterday sort of we had health watch at the meeting yesterday, which is very good, the ambulance service, which is unique. So I think it's great to see that we've got all partners, but the GP voice is missing, and I think I would echo the comments, but there is a welcome invitation in terms of if we can see how we get that voice into the UEC board.
Yeah, and it was just to support that. So one of the things that I've been working with Gareth as part of the team on is introducing we haven't decided quite what we're going to call it, almost a prevention type of a work stream into UEC, so that we are focused on that proactivity around making sure that we're making use of all our resources in the right way. As you mentioned, Julie, we made the call out to general practice to say the system is in extreme risk. We've got patients at real risk of these disorders, and to their credit, a number of practices with PCOs did step forward and do that. And I think that's a real credit to STW general practice, because actually a lot of systems really struggle with that. But they stood up and played their part. But it's about how we do it in a planned, proactive way and make best use of those that offer and those skills. So we're hoping it will form a really structured part of the work stream and be something that really does make it a change in terms of that.
You're going to go to Meredith next, and then I'll work my way around.
Yeah, thanks very much. I've been very struck by the discussions today, how we are recognising that the three shifts are fundamental to health and well-being of our population for years to come. And Julie and Lorna and Joe, they've all picked up the fact that we need to be reducing the flow into UEC, which is absolutely right. I just want to really reiterate that point, that if we think prevention, as Paul's been talking about, so articulately, the neighbourhood work, if all of that is the solution, I just want to really make sure that our review of UEC in March or is not about UEC, it's about all the steps that are going to be taken that makes UEC less of an issue. If those two things aren't all together. So it's not just about GPs, it's not just about ambulance, it's about the whole picture. I really hope that we can think of it in those terms. Otherwise, I think our conversation will be at the same time.
Very good point, Meredith. And then Paul, and then
just a quick one for me, really an observation. I think what's really important is to understand the patient's experience of any work that's being done to try and improve these things, because that's what we need to see evidence of. And I know that there's a lot of work happening, but it'd be just great to see what difference it's making on the ground. And so that's, if we can help with that, then we're happy to help. But it's a really important part of this in order for the public to understand what is happening and the value of it.
Okay. Paul?
Yeah, just thank you, Ian, for the positive words. I think that partnership approach during critical incidents is really important, but it's really important anyway, just full stop. That's how we're going to deal with some of the issues that we're dealing with. And the fact that we have met our KPI on complex discharges per day, in fact exceeded it, and continue to exceed it, is really important. I know our TICAC team is really, really important in that process, and the way that we develop together and the way we work together on making sure that the right response, and exactly what you were saying about it being about people, not about numbers. It is about getting the right response for the right people at the right time. And, thank you for the words. I think it's really positive. I think your words on review is really, really important, that we need to be winter ready in March rather than in October, and we should be talking about that now. And I welcome that.
Yeah, thank you. Mark?
Yeah, firstly, don't underestimate the pressures that we've had over the last month or so long, and for everybody that's been involved in that, I don't underestimate that. I kind of link, my point links into lots of others, and it is about some of those high volume service users that about. I'm conscious that in other areas, lots of focus work done on individuals that actually create quite a lot of demand, and if that demand isn't serviced, they end up calling an ambulance or being in A&E. So we've got lots of data here that we're kind of reviewing. I'm just keen to sort of see is that an element of what we are building into, learning from this year, planning for next year, kind of linking into different services to look to make sure some of those individuals that you could almost predict might end up where they end up, how we're working collectively to make sure we're doing whatever we can to provide them the support they need in the community, and not resulting in them slipping into adding to the demand and pressures of the hospital.
Thanks. Andrew?
Yeah, I think the winter discussion is where all of today's discussion so far will link up, aren't they, about some of the stuff Paul was talking about, even going back to today's talking about the money, look across the system, not just at individual trusts. So really welcome the focus on pre-hospital, but also post-hospital. And although we're doing well on some of the discharges, there are still days when party that you don't need to be there because they've finished their episode of care. And my only other comment is looking at other people's performance. Interesting though it is, it's not a group you particularly want to mix with, because everyone's performance, let's face it, is pretty grim, isn't it, when you look across the country? And I think most days we're still providing care that we wouldn't really want to be providing. Our staff feel it, our patients feel it, and that's why it's right that we remember these numbers are other people's loved ones, as I keep saying, back at the rent. So yeah, welcome the focus on what I used to call the keep out, sort out, get out approach to life. We keep people out of hospital who don't need to be there. If they come into a hospital, we look after them really well. When we finish with them, we allow them to go back to wherever they need to go. And our focus has to be on all three bits of that. And it does have to be joined up, which is, I think, where all of our discussions have been today. Welcome the praise for the significant efforts that people put in over the festive and New Year period. More needed, isn't it?
Okay, thank you. Right, good discussion. Next steps. I think what we're looking for is clearly a re-engineering or rethinking around community crisis intervention, social intervention piece. I think we're looking for a rethink around the involvement of primary care, social, health and shop control. There are examples of rapid intervention teams, but I'm not pretty clear as to how widespread they are. So there's a whole lot of work to be done around this, but I think also looking at practice elsewhere. I was over the last few weeks, I've been looking at the role of telemedicine in ambulance services, the role of greater medical input supporting ambulance. And the other aspect to all of this is the social crisis. So your remit is very broad, but I think it has to be broad to actually bring about change. But I think the key focus is if we can focus more on the preventative side, then hopefully the fewer people will turn up. You see it to be there. Do you feel that you have the research-based understanding of how to innovate and change this question? Yeah.
So yesterday we started on the what does 25, 26 look like? It's nervous on to be in the situation that we're in all the time. I think the other thing from a staff perspective, I think we've now got the capacity and capability and leadership in coming into the organisation so that we can lift our heads up and look beyond how do we sort the what's happening here and now. We've certainly got the support. We've also, in terms of picking up the point about a detailed report that we looked through yesterday about we do differently. It wasn't the right read, wasn't, there are lots of other things that we can do some fix on that. So I think I think we've just got a great cycle of keep doing what we've been doing in terms of just trying to get through.
Yeah. But it's also that integration approach with social staff, care staff, volunteers, families, GPs. It's that whole gamut that we bring to. And I suppose my question is, bearing in mind we're aiming for 25, 26, we have to be moving pretty quickly to get changes in place for that, because it's only beyond, 10 months away. Do you feel we have the urgency and the enthusiasm to go?
I do, and I think we need to be careful with winter's not the panacea of everything in terms of emergency care, because we're planning for Easter. Actually, the end of plan season was England, and also Cambridge Conference. We know where the patterns are. If night follows to go, you can see it. So I think we've got the energy. I think the point that so it's great having them there yesterday, and we've said that we want Health Watch to come in, because I think the other thing is it isn't all broken and it isn't all awful. And I don't want to think we've got residents of SCW that don't want to come into our hospitals. So I think we also need to be brave about saying when things are getting better. I accept Andrew's point as well that actually, all of us came in to deliver something very different. So I think there's a balance about reassuring people and working with them where they can see things getting better. But in terms of the energy, it was on Teams, so it wasn't if we were offering chocolate and biscuits yesterday, but the UEC board was probably the most engaged in terms of people wanting to come and enjoy it. And as I say, the ambulance service being there is really fundamental. So I think what is the point that Nigel made earlier, how do not for everybody to have to turn to that meeting, but how do we get the upward reports that we know that other parts of the country are doing their bit that contributes that we just have to
Thank you.
There's a sort of follow-on. We'll take you back to the initial presentation, which is despite the increase in pressure for like 4 years, and certainly the level of infection rates 3.5 times over what we saw in the last 2 to 3 years, the norovirus and the COVID toxic mix. That was palpably greater than the previous years. However, the system managed and it felt less chaotic and certainly more joined up with greater safety and care that was provided. I take it back to November 2023 through to the end of January 24, this system declared 27 critical incidents. We declared one.
Okay. Very, very quickly. I'm very reminiscent to say very, very well done. Amazing performance from everyone involved. So thanks very much. The other thing is that a lot of this is about the behaviour, the understanding, the insight and knowledge of the population. We just want to make sure that any work we do is focusing around helping people understand they have a role too. So communication plans don't kick in every
I think very disappointed nicely for what I'm about to say. NHS want to push forward a new way of looking at patient segmentation in terms of needs. I think it ties into it's a picture anymore to allow us to focus on our certain time better and addressing the need at the time basis, especially when we see that is coming. So I think that's going to be really interesting how important to turn the corner using what time forward this year. And I think that will be part of our strategy going forward anyway.
Just a quick one from me as a member of the public, patient and a carer in particular. I've really witnessed in the last 2 years the challenges that the ambulance service has, and the thing that has really arisen for me is that quite often I'm in the back of an ambulance with an elderly relative, and none of us want to be there, but the clinician hasn't been available for the ambulance crew to be able to be told that they don't need to convey somebody. And at some of the care homes that my relatives are in, it's just because they've got a terrible phone system. So even when they ask for information and advice, they can't get it back. So I think there's something as well to be said about some of the infrastructure support as well, because if ambulance crews like don't want to take someone, but they, you know, the clinical priority thing says they've got to do it, they've got no choice. And the only way I've, as a member of the public, been able to override that and support them is with a lasting power of attorney. And so I do think there's a role for the public in order to take some sort of level of power and responsibility. And I do think a lot of work still needs to be done on the detail that is in respect forms, because they are not helpful to ambulance crews quite often, and they're left not knowing what to do for the best. So I just think there's a much bigger piece to do than what's already been mentioned.
Well made, thank you. Okay, next step. Because of the importance of this, we mustn't lose what we require is for each board meeting to make forward what's been done and get clarity about how the system is going to change in response forward. Good, thank you, well done. Next item is the integrated care system report.
Thank you. Board members will see that we've been looking to streamline and update the papers that we present to board to make sure that no pertinent issues and items are readily accessible for those who are accessing our papers. Of course, we provide tracking data to these, so for those people that look to dig into the graphs and charts, it's there and available, but we just wanted to make sure that the key headlines are here. You'll see from the summary report that, as I've done in previous meetings, we're now including our highlights up front in the paper, particularly to reflect those areas that are showing improvement, but also to make sure that it's clear where we know there are areas showing concern, and hopefully the content of the report provides assurance in terms of the actions that we're taking to address those. I think it's fair to say we know there's more to do in a number of areas, but actually, whilst in some areas we are not achieving our targets, we still think it's important to where we're seeing improvement. We just need to make sure that through our work, we're sustaining that improvement, and we will reflect that through the reports that we have. Key messages, aside from the performance message, and just in terms of finance to flag, we pick up our month 9 position as part of this report 3/4 of the way through the financial year. We have just under a 16 million adverse variance to plan year to date, and we do have significant concerns that we will not be meeting our forecast target for this year. We're in conversation with NHS England at regional and national level about the scale and extent of that and the actions that we're taking to address those activities, not least because we know that the figures that we exit this year with form the foundation for our plans for future years. And certainly, again, to sort of reflect really the conversation we've been having today, taking a medium-term view and not just a short-term view is really important when it comes to financial recovery. It's going to take us multiple years to become sustainable again, which we all know and recognise through the discussions we have. So 25-26 as year one of that plan is really important for us to focus on. There's reference in here too to our capital spend. I just wanted to give assurance that whilst we are behind our expenditure plan for capital, that's actually not unusual for capital expenditure. We did provide assurances from all boards through to NHS England a month or so ago that we will be achieving our capital spend target for the year. I think that's really important, actually, making sure we can exhaust every kind of capital resource that we've got to support the services that we're delivering is really important. We can always do more to get it on, but it's really important that we've got I'll pause there, but myself and potentially colleagues from providers who want to comments or questions.
Question? Got one question. It relates to 25-26 position. But bearing in mind that the NHS want to change in the operating model, we become more of a commissioner and less of a provider performance. Do you foresee our integrated performance report?
I think we'll make that assessment over time, to be honest, because for me at the moment, the key headlines that this board needs to see are the ones that we already report on. And for me, it's important to be clear about whether we're meeting our constitutional targets and any local targets that we have. We obviously have a statutory duty around finance, and quality plays a really key part of the reporting here. I think where I would see it change potentially over time will be an evolution to perhaps reflect more on some of our strategic aims and use the development of our place partnerships, for example. If we can draw more information in here in terms of outcomes, draw back to the public health, population health dashboards and things like that, I think they will really help to enhance our discussions. Obviously, the use of that through our reporting, but we can put some centralised data into here as well, if that helps.
Any further points? No.
Just a quick point for me to just remind everyone that the BCSE is also struggling massively at the moment, and so many of us are not really financially viable or sustainable. So just you need to have that on your radar.
It is very easy. Thank you.
Sure.
Just to say in terms of what I hope will start coming through a lot stronger is the work that we're doing for the obviously with the paper that we've had in terms of the elected and obviously have a support phase in terms of the work that she's doing. So I think it will come out more, which will get us into some of the diagnostics. But again, it goes back to the numbers. I think the patients that are waiting on it, but something or could be our points about how we can support them. I think that can be a bit stronger in the next few months.
Okay. I suppose just linked to your question, Chair, about the performance report. We have the NHS is very good at looking at a whole range of targets which appear each month, and we've been talking about a whole range of strategic changes, health management changes, which won't necessarily see a massive change month on month. Health inequalities, for example, we report some of that activity on a quarterly basis. There'll be others which, again, colleagues will be much more able to advise. So I think, and clearly, people like myself will absolutely work with Claire and colleagues on this, but I think we also need to. So I think there's opportunities for in adding to and expanding the sorts of reports, particularly in line with our commission intentions, but it won't necessarily always look the same, and that should be right. As opposed to just saying, well, we haven't had a monthly update on X. Well, nor would we expect to necessarily. So if we're going to expand, then we also need to look at
Thank you. Any other points? Moving on then to delegated special.
Thank you. I think just very briefly, the board will be aware that for this financial year, we received the delegation a number of specialised services. There will be a further tranche of those services coming down to the ICB on the 1st of April. There's nothing for the board to do today. We will receive a reporting model for a final decision. But this report gives some information really so that doesn't fall behind when we're asked you Mark to make that confirmation of the delegation.
Any comments? Okay. Moving on then to amendments to the government.
Apologies to me again. We've been doing a lot of work in the background to make sure that our governance is fit for purpose, and particularly now that we'll be operating as an ICB for a little while, trying to see where we can streamline things, do things better. And so the paper today is a reflection of our recommendations to make those amendments. What we're looking to do fundamentally is to really bring more clarity to commissioning, our role as a commissioner, and thanks to your comment previously, Roger. What we found at a practical level is that it's very difficult to transact some of our commissioning functions through a strategic commissioning committee, not least because we're pulling into operational where we want to have the strategic discussion, and actually we have quite a lot of confidence in that space. So we've done a lot of thinking about how we can better support and deliver that function and avoid those conflicts and issues. We've made some other changes that complement thinking that will align our process more with the pillars suggested by Darcy's report, and generally we've taken the opportunity really just to tidy up a few things when we've noticed that we've got some areas of rub or issues, just to make it absolutely clear around roles and responsibilities, and that's both for individuals and for groups as well. There are some recommendations in the report, obviously the approval of the proposed amendments, but also around the appointment of chairs of the new committees that are proposed, or changed committees that are proposed. I'll pause there and I'm happy to pick up any comments or questions.
Any points? So the principal aim of all of this is to ensure that we as an ICB largely in the government's direction of travel. That's really the summary. I've spoken with Kathy Pert around the strategy and prevention committee, and I think that's going to be very important going forward, particularly working with colleagues and partners in local government and SHIP and the prevention side. The system transformation and digital group very much headed really around the transformation of the delivery side of the services, but also emphasising that we can't lose sight of the importance of digital. Okay. Julian.
With regards to the committee structure, obviously it was really designed following the review by the government.
Yes.
That's the bit, and we're now saying that it's not, the bits that aren't working properly. Has there been a formal review? Is it planning to be a formal review of how the committee work? Is it more just the feedback of how the committee are meeting? I don't.
When you say formal review, Julian, what do you mean?
Because obviously they had a review, which government came in and reviewed the system, and so actually we need to restructure, rename them, and be clear about what's a committee and what's a group, and how to flow through. And then we're now saying that since that review, we're now not happy with the way some of the committees are functioning. Is that correct? Is that what
I think this is just an evolution of us settling in as an organisation and as a system. So we have some very practical recommendations from the Good Governance Institute. They're an external body, so it's good because they've got experience of in terms of drawing benchmarks and comparators. Some of the changes are done on the basis that we're practically kind of living and breathing this process, and actually we don't want governance to hold it. Kind of chimes with what Dave was saying earlier. Really, we're trying to streamline what we do, not make it more complicated. We need to be free to put in our decision making. So I don't think we necessarily require a formal review, I think, in the sense that you're asking, but this is about, as a board, making sure that we're content that we are assigning the right responsibilities and accountabilities to the right places to really move things forward and get the job done.
I think that's going to have to give us sort of a standing outside of obviously on the board and sort of other things that some of the times the processes don't seem that clear and kind of quite funky.
Yeah.
And it is difficult sometimes for even get members within those committees to articulate fully how things are working. I think other things are working really well, and some of the matrix working and some of the working for huge benefits, but I'm not sure that the committees are working as smoothly as they could be, really. I think some of the splits around, and I'm glad it's been highlighted about having the commissioning meeting. It's very hard to have the fighters on there, managing the conflicts. Conflicts always get happening, it's how you manage them, but it just seems that everyone's got a conflict, excluding all the conflict, you'd be left to no one in the room. So it's just more about, it's positive, let's be positive, not critical. I do think that a little bit where an outsider, or semi-outsider, it feels quite funky and quite times not clear where the routes are.
And this isn't a static thing. It's not a job we do once and then leave. There's a constant check and review of where we're at. We also know we've got quite a broad OD piece in this, for want of a better description, for members of those committees and boards, but also for our staff as well, so that we can most effectively navigate through some of that. One of the things that we're doing this year that we've not done consistently previously is to make sure that we are encouraging our direct committees of the board to do that reflection piece at the end of the year. So how effective has this committee been? Or do we feel we're discharging our terms of reference? We'll use that process to pick up any learning and reflections as well. So I know Alison's not here, but she's got quite a large programme of work, both in terms of communication of how things work, the OD piece that sits around that for everyone, but also then some of the feedback loop in terms of let's just not sit on it. If we think we can improve, we will. And this isn't saying that we've identified gaps or significant holes in what we do, but we think we can do it more effectively. So this is what we're trying to address.
I just wanted to, I think I might be echoing a little bit about what Julian's saying. As a sort of an independent organisation, I'm an attendee rather than a member of this board, and I go to a lot of the committees, for which, I'm pleased that door is open. What I would really like to see is a much clearer depiction of the impact and outcomes for patients and the public of the work of these groups. And I know that those improvements can take time. What I often talk, and I think that would really be helpful for staff as well, to see the impact of what they're doing, because people are working very hard. And it would certainly help the public to understand the advantages of the different transformation programs and projects that are taking place, so they can see the value of them. I know that you get asked to deliver certain amounts of data to NHS England, but one of the things that I'm always a bit struck by, for example, is the dementia diagnosis data. For me, the question is, well, what next? My dad had, we couldn't tell him he had dementia because it would have sent, he was very depressed about that very idea. So for me, what after the diagnosis? And that's, I think, where the public often will sit. It's about what's beyond those figures and what's the impact on them and what is the service available and the current capacity of that service.
Thank you. I'll come back to that.
I think it's important. I mean, if I look elsewhere, and I look at what we do, as a sort of independent sort of view on it, I think our governance is overly convoluted. I think we take much too much of a process view of governance rather than an outcome view of governance. For me, government is only there to deliver the things it's supposed to deliver and ensure that that's delivered and you manage the risk in terms of delivery. And so therefore, I think we need to take much more of a what are we trying to achieve starting point from governments, whereas I think at the moment we've got, it feels to me, some groups and committees that are there to service the process rather than the outcome. And I do think we can streamline, and if we look elsewhere, you will find that there are a number of systems that work on much more streamlined governance structure than we currently have.
Yeah, this is three purposes. First of all, our intention is to become far more delivery and outcome focused. And Ian is heading up a program management approach. The second thing is we must ensure that our strategy and our delivery is aligned to what the government wants us to do in terms of the future. So again, this is about more explicit tying in of prevention, the digital changes, and so that's why, to some extent, the transformation and digital group that Andrew is chair will be critical to all this process. But it's sitting in the right place because it's the provision of service that needs to happen. On the prevention side, we felt that that needed to be explicitly stated now because it then partnership particularly far more explicit. But then on the commissioning side, we as an ICB need to focus on our performance more as a commissioner. And that is very much an internal discussion around the decisions we make as a commissioner, our performance as a commissioner. That's why that committee was set up. Because there are conflicts around that. That's where we are. This is not tough. This is how we're going to try it. We're going to make sure it's as best we can. But at the end of the day, this board, particularly with our external colleagues, can challenge us and bring it on because challenge makes it better. Okay, thank you. Good. I'm sorry we're running a bit early, but no. Moving on then to the board report.
Just one thing to note, Roger. The last board meeting, I reported that the Quality Performance Committee was anxious that the progress wasn't being made around diabetes transformation. I'm happy to say one day later, Lorna came along and the way that they're really strong. The discussion was confident that things were on the right things on the way in the right time and steps that are in place. Obviously, we need to see the steps happening, but just quite a bit of assurance.
Thank you. Any points on Mary's report? Okay.
I don't think anything to highlight. So we reported the internal audit committee auditors who are pretty much online and now starting to think about what the program should be next year. It's interesting to decide whether you want to go with the real risks or the routine or
Finance committee, Dave?
Yeah, so the paper in here is minutes of the meeting in October. So we had a committee meeting yesterday, which is probably more relevant to update people on. As I mentioned, and as you've seen, we're looking potentially at an outturn although we are officially still maintaining a forecast outturn of a break-even position. That's simply because NHS England haven't asked for formal reforecast yet, but the position essentially is that we've been looking at an outturn of about 20 to 30 million pound deficit. And we should remember that's post deficit funding that we received in the year of 89 million, which was to fund our original plan, which was a deficit of 89 million. So in effect, we have delivered a deficit in considerably above 100 million. So we also at the meeting yesterday, we reviewed the first draft entry point for 25-26 in discussing the planning process for next year, and this shows a deterioration in our position year on year, leaving us with a very substantial challenges in the coming weeks. Remembering our headline submission to NHS England for our plan for 25-26 is expected on the 27th of February. And I think there's a degree of nervousness of whether we have the urgency required to make sure that our plans are going to be in place. NHS England have been saying so far they really don't want a repeat of 24-25, where organisations were allowed to sign off plans with substantial elements of unmitigated risk on the basis that somehow or other miracles will happen during the course of the year and those plans will be closed. That they're not prepared to go down that route this time. So I'm nervous that business cases for a lot of our transformation programs need to be stepped up with a degree of urgency to get them into a place where we can identify what our position will be by 27th of February. We also reviewed our updated medium-term financial plan, which has been updated in line with the worsening position post its original drafting in September last year. And this indicates extremely challenging efficiency targets will be required to return the system to break even within 2 or 3 years. I think it's true to say that those efficiency targets are moving beyond the realm of possibility. We're looking at potentially to deliver a break-even position within 2 years, somewhere in the region of 9%, over 9% year-on-year efficiency delivery, and that's not really achievable. So I think we are having to move into the realm of the difficult decisions, and I think we need a mechanism, and I'm worried about the governance structures that we have in terms of timing, not in terms of have we got the right governance structure in place, but in terms of timing, because we're going to have to, as a board, sign off on this plan. And at the moment, I can't see a way of doing that without having a discussion around some of the decisions which we've got to take. We do have productivity packs have been delivered to all systems and all providers from NHS England, and they are based upon benchmark data across the whole country. And essentially what they're taking a view on is that everybody, all systems or all providers who are below, in the bottom third, and so below the 66th percentile, are going to be expected to target delivery of a performance equivalent to that 66th percentile, recognising that 66th percentile will itself move and improve hopefully during the course of next year, plus the 2% underlying business as usual. And although on those benchmarks, they do show that we have a sizable aggregated opportunity, the deliverability of those opportunities, both in terms of the timing of the delivery of those, is still under evaluation. So I think it does sound bleak, but the situation is very difficult. And I think we do have very challenging a few weeks ahead in terms of getting a headline plan together that will be acceptable by NHS.
John's about the £120 million deficit we give with the £89 million that we've been given.
Yeah.
How much of that is a sort of recurring deficit?
That's the first question. The second one's video connected to the clubs. And that's about the governance and the process of making the decision about the drastic changes, about the fact that may require public engagement and public consultations around what are significant changes and what, and I suppose tied into that, and we want to have flagged quite a few times, flag again, is that we need a process for deprioritisation, and I don't see that we've had a process for deprioritisation. Clearly, if you go and ask people what they want what they need, and it's about how do we then get that information and actually say, well, actually, we have to make stringent cuts, drastic cuts. We're going to have to stop doing some things and not replace them. We have to do some things. A lot we can do more efficiently, and you can save some money, but it's not going to make that, that dramatic 9% or whatever by a year. So it's about how are we going to, what's the process for getting that prioritisation process? I know we've got a finance committee that is probably key to it, and having reassurance that there is within the management structural way of getting an agreed plan. Indeed, I think firstly the first point underlying is of that order. It is substantial. One of the things we are doing much more vigorously now on the finance committee is tracking our underlying performance, as well as the run rate. So we are focusing very much on that delivery. It is of a sizable, there's a sizable problem for us. In terms of the structure, then there will be, as indeed we've seen elsewhere in other systems, there are going to be a lot of opportunities to think about some things we can do, which will not necessarily get us into a position where we are looking at public consultation. I think the other challenge with that, of course, is that in my view, we have to look at this beyond the finance lens. We've got to associate these with quality impact assessments. We've got to be very clear. I mean, because if we're looking at finance, you can argue that you could deliver a break-even position tomorrow, but that would have huge implications for our population. So the really important element of our plan, I think, is going to be those quality impact assessments, and being very clear about what that means. But back to your main point, really, is what's our process? And I think I'm probably going to have to throw that back to Claire in terms of the process.
Yeah. So what drilling into process, fully support what Dave just said, and absolutely, we're talking already about hard decisions. Productivity packs are highlighting areas of opportunity, as you'd expect, but they're also reinforcing some of the messages we're getting from some of our leads in terms of we think we've exhausted the low-hanging fruit, so we are into the harder decisions. I think medicines management is one of those areas, as an example, we were talking about in our ICB team meeting yesterday. We have what is called a strategic decision-making framework, and that's not just about what we want to put money into, but also considering where we think we need to take money out because we could better deploy it somewhere else. That's not a finance framework. It's deliberately not built as a finance framework, although of course finance is in there. It very much pulls together all aspects of consideration. So whether that be quality aspects, finance, and performance or operational issues, and impact more broadly on the patient, which is so important in those decisions. And certainly the work that we're doing now around, okay, so what are the hard decisions we think we need to present here to talk about will be based on that methodology of that framework. So we absolutely have that rounded consideration. And just for assurance as well, where we have an efficiency programme, no efficiency piece of work goes forward, and speaking on behalf of all partners, not just the system work, without having that corresponding quality, inequality, impact assessment. It's so important that we do that.
Just one final point, I think, Julia, as well. I think when we look at, if we phrase all this in terms of efficiency targets, I think sometimes you can get the wrong impression, which is we'll carry on doing what we're doing at the moment, but we'll just do it more efficiently. That's not the answer. I mean, we've mentioned today so many opportunities where the wrong people are turning up in the wrong place and care is being delivered in the wrong environment, etc. And those are things that have got to really play into actually how we sort and genuinely transform how care is delivered at the right point at the right time and in the most cost effective way. I mean, you've got just basic examples. I mean, one of the things we looked at in Southampton is we're prescribing OTC medicine in hospital, which patients are paying more for anyway than they would do in the local clinics. It's just basic, simple things that we just think, well, why are we doing this? And although that's not much money, there are many other things that we do that sometimes we just need to have a bit of a sort of sensible lens on.
Thank you. Very much.
Thank you. Thank you, Julian. You queued me up nicely, and I'm going to deliver the punchline. Just to be wary when we talk about consultation, we need to make sure we remember any service change, range of service or nature of its delivery, any change has to go through a process of involvement. If we don't, we'll use all our savings on court proceedings. Sorry, I didn't want to cheer you up.
All right. Okay, Andrew.
Really quick one. I mean, it's the twin track process, isn't it? Absolutely, we have to do all the efficiency and productivity and associated matters. My only caution on that is packs of information and benchmarks don't actually make change happen. They just tell you where to go looking. So, let's not assume that we've answered it by identifying it. I would absolutely agree with Dave. The big money is in the transformation and the change of offer. And that doesn't have to be a bad thing. We go down, we're going to impact quality and safety, can't we? You don't have to say this is going to be a bad thing, but ultimately we do have to live within the resource that we're given. And, borrowing 100 and whatever million from somebody else isn't a sustainable position, is it? So, we have got some big decisions, but let's not make that a negative thing. We've got some of the great things we can do. Some of the left shift stuff, the 3 shifts, however you want to phrase it, there's some big changes out there that would be better for population. But ultimately, whichever way we do it, we have got to do it. Let's never sign up a plan that we don't believe in. I think we've got form on that, the NHS. We don't go near this.
Yeah, and I guess in terms of the process that Andrew's described, what we're also trying to do at SAP is that those 8,000 people we take with us and don't do too, because what we don't want to do is split the spear. So this is as much about culture and what we're trying to say, and it's interesting. As soon as you say efficient, somebody hears I'm not being efficient, and it's productivity, so I'm not working, and I can tell you they are on. So as Andrew knows, what we've done in the last, if you think 3 years ago, SAP CRP program was 8 million. We are trying to deliver 36 million, which is huge in itself. So I have written out to all staff in terms of their approach, how we can do things better in terms of reduction of waste. But this is about culture, because if we go in and if we take this message back into our organisation, it's going to breed fear. It's going to breed fear in terms of patients, and it also in terms of our residents. So we're trying to do this at the same time, that this is something that we can do and we can transform. So I think we've just got to be really careful with the messages, because as much of next year is done, this year the second thing done as well. And I think the other thing that we're trying to be really careful is that actually all roles and all staff are valued and have a role to play. So what we're trying to do is yes, there's the narrative about actually how we can be more efficient in terms of back office, but actually everybody contributes to it. So it's not that we aren't, as I say, we have written out to all staff. We've been very honest for a change. The approach that we need to that will probably play out more into the organisation. So I guess it's as well as here, right? Than only in terms of the approach we'll take.
Lynn?
I just wanted to echo really what Joe said about that, because for me, those frontline staff are really keen getting the messages across to the public about the fact that it's not just about saving money, but it's also about having new approaches to services. And there's a huge education piece that every single member of staff needs to be part of that. So they're giving the right messages to the public rather than saying, I need to complain about that, because that isn't of itself helpful. But also that engagement with the public, as Meredith says, about helping them to understand that this is just a necessity, and that they are part of this conversation, and they need to be in support of anything that happens. And so it's about how you manage that.
Okay, good point. Any further comments before I try and wrap up? So my next question is the timetable for this board's involvement in agreeing with budget for next year. Because bearing in mind we don't need.
It's likely that we will need to meet somewhere in the interim. What we're trying to do at the moment is assess the best way to organise ourselves so that when we do come together and when we come together, we can be most effective in those conversations. So we're still waiting for some additional guidance from NHS England. We've got some new milestones in terms of initial return on the 27th of February and then another return at the end of March. We'll have our board meeting at the end of March, so that's quite a pivotal point. But it may be we need conversations before then, actually, given what Danny's highlighted and where we're heading. We will keep board members briefed and pull you in as practically as possible. We're also having to coordinate individual boards and their decisions with what we then bring together as a system. So it's logistically a nightmare. Let's leave it at that. But yeah, we'll keep you briefed and be clear about the ask when we're clear. So absolutely.
And the second part of all this is the big ticket transformational piece. And is this a combination of Nigel and Ian working on? Because we have our commissioning intention, but you could say you could also have decommissioning intentions. Convince the outcomes are there. I mean, how's that process going to work? Go away and think about it. Yeah.
Can I also stick my hat in the ring to be involved in that? I think it's really, really important. But
Yeah, no, I agree with that point, but it's an important point that we can't lose sight of.
Within our commissioning infrastructure, we have a working group where, when we talk about the strategic decision making framework, that's where we make those assessments and recommendations, which involves clinical, quality leads, and all the corporate functions that usually require around you to help them in recommendations and decisions.
Is that needed for your?
We can set out process the board, that's fine, and then what we'll also be able to do when we give our feedback and comms, it will be clear about those recommendations, but we will understand the origin of where they've come from at that point and how we've come to those conclusions to move forward.
Good, thank you. Right, moving on to the next item, the Remuneration Committee. Nothing to add here, Mario?
Just two items we discussed last week. One was the terms and conditions, and the other one was just bringing up the process around if we wanted to recruit a clinical lead from the GP community, we just need to unravel the technicality.
That's okay. Just on the transformation group. Claire.
The report's there for information. I wasn't actually present at the meeting, but specific questions I'm sure colleagues who were in this subject.
And Andrew will be picking this up. The Commission Committee and the report.
If I may, the report in the pack is
September meeting. I think one of the key points is much as the colleagues meet in colleague we set that one to do that same question development, so partners across the system, and that's really quite useful when we talk about some of the strategic programs of work we're talking about. That's been in place since October. We'll get the report from the meeting that we again held just a few days ago. I think the only point I would add, which I think we can brief more detail, is we've got a report and information on the work of women's health ops, and I think that's just a really good example of how it's been working. Really important input from general practice, but with other partners, including the voluntary community sector. So again, a part of all of that we've been talking about.
Okay.
It's National Women's Day at the beginning.
Martin, anything to report?
Yeah, there's no paper, Chair, because we didn't have a meeting before the cut-off date. We have had a meeting since. We sort of picked up on effectiveness of committees, trying to be clear as to what are we looking to achieve as committees. That's some of what we are doing within the PCI, doing a bit of reforming and installing to be really clear around terms of reference, priorities, cycle of business, work plans. So that's the work we've been doing. I'm hoping that come the next ICB, we will have an agreed terms of reference for sign-off by board. That is my hope. We're awaiting the findings of the external ICB people review. I think that's been done, so that hopefully we'll get some recommendations coming out of that very soon that will help to be fed into the committee and to our structure. And then likewise, we're looking at the risks, people risks, to make sure we're really happy with the risks, and then hopefully we'll be able to get some of those risks featured at an ICB level around the people agenda. And then as well as the committee itself, it's been really clear as to the priorities of the subgroups. So we've got 4 subgroups that report into the people collaborative and then into the committee that I'm currently chairing on behalf of Harry. But we want to be really clear as to what the priorities are for each of those groups, so that we've got a real focus within our committee that we can report up to the ICB. So work in progress. We are getting there. Great for the body that's helping me to.
Just an idea, is it worth you also having a chat with Andrew as well? Some of the demarcation around people's strategies.
Yeah, I mean, great thing is Andrew's a member of the committee, so he's in on the conversations, but absolutely the individual piece of the happens to the way forwards.
Thank you. Right, moving on then, next item is review of risk. I think risk is pretty apparent. Any other business? Nothing's been reported through. This brings me to thank everybody for their participation in important discussion. And to finally again thank Julian for coming on today and all the best. We're now resolved that we meet on the 29th of March here. Public interest. Yeah.